For relapsed refractory FLT3-mutated AML, the standard of care is now Gilteritinib. However, in the majority of cases, that therapy is not curative, and eventually the majority of patients will relapse. So our institution did a retrospective single-center analysis of our 25 patients who had been treated with a different approach by combining Gilteritinib with Venetoclax, low-dose Cytarabine, and Actinomycin D, so a quadruplet regimen, as a salvage for FLT3-mutated relapsed refractory acute myeloid leukemia. So from those 25 patients, we included 16 who would have met the inclusion criteria of the phase 3 Admiral trial. Those 16 patients were included in a separate analysis, and we know that the median age of those 16 patients was 64 years old. They received one prior therapy line. 50% of those patients were exposed to prior FLT3 inhibitor, which was mainly midostaurin. The median ECOG of those patients was 1. One patient had relapsed post-allogeneic stem cell transplantation. So the therapy resulted in an overall response rate of 100% and an 88% of a composite complete remission and complete remission with a partial platelet recovery rate. So an 88% CR plus CRP rate. This resulted in a high bridging to an allo transplantation rate. So more than 2/3 of the patients, of those 16 patients, had been bridged to an allogeneic stem cell transplantation. Almost all patients required only one therapy cycle of this quadruplet regimen and then could proceed to an allogeneic stem cell transplantation. So the high numbers of alloSCT translated to a promising overall survival. The median overall survival was 32 months, and the 24-month overall survival was 70%. The early toxicity and early mortality at day 60 was 6%. So overall, this quadruplet regimen has been established as a standard of care at our institution, and we're hoping to initiate a phase 2 trial.